Hello and good evening. It's good to be back. It's Monday, 8 p.m. UK time. So, as always, it is time to start our live event. I am your host, Caroline, and please let me know that you can hear me loud and clear. And of course, we do have another special guest with us tonight. As you can see her already, is Dr. Uliana Dorofeyeva. How are you feeling, Dr. Uliana? It's good to have you back. Okay, Dr. Uliana, can you hear me? All right, so I guess Dr. Liana cannot hear me right now. So everyone else, I guess you can hear me. So please let me know. But let me see. Dr. Liana, hi. How are you feeling? And I hope you can hear me now.
Hi, Carolina. I can hear you very well. I'm
Yeah.
happy to be here. Hello, everyone.
Hello. All right. So I was worried for a second because you didn't hear me, but it's all okay. You can hear me now. So thank you so much for confirming that for us as well. Everything is okay. And as I mentioned, we will start our live event tonight. And as you know, this is another Stronger Together live event, and we are here to support you as we know how stressful, how difficult it is when it comes to IVF treatment. So we want to just simply we want to educate you. We want to help you out with your questions, and of course, we are inviting lots of top fertility experts so that they can help you a bit in those. Definitely difficult times for everyone right here. But I'm glad that we are all here back as Dr. Liana. It's back with us once again. I'm always really happy that you are always brilliant here. So thank you so much for joining our Stronger Together initiative once more. And of course, as always, I want to thank to our ambassadors and partners. You can see them right here. Without their support, it would be very hard to simply bring this Stronger Together initiative. So thank you so much for your support. And today, definitely, we have a topic, a difficult topic, but on the other hand, it's also, I would say, hopeful topic. So it is about IVF age limit, how old is too old for IVF treatment, and when should we keep trying. So Dr. Liana, as always, will start with her presentation, and afterwards it will be time for your questions. So all you will need to do is just type those questions in the chat section so that Dr. Liana can help you out a bit, of course. So you can do that now. You can type those questions now or later on. Of course, it's up to you. But we will answer all the questions right after Dr. Liana's presentation. And I just also want to mention that Dr. Liana is IVF specialist, director of international cooperations at IVMED Fertility Center, which is located in Kiev, Ukraine. And she's also medical director of OVOGENE Egg Bank. So once again, thank you so much for joining us. And well, are you ready to begin with your presentation?
Good evening, everyone. Dear Carolina, thank you for such kind introduction. I am happy to be with you once again. I really appreciate the work which is done by IVF Media, Egg Donation Friends. I'm sure that Stronger Together is a great initiative for all of our patients, for us, even IVF specialists, because we may talk to you, we may share our knowledges, we may develop new strategies in these really complicated times for everyone. In the times of we are talking during the COVID era, because the webinar will be recorded, and I hope that we will just remember these times as something which passed very soon. And this is a time when we reevaluated the most important things, and we will be talking about something which is most important, the parenthood and age, because age, this is a crucial factor for every one of us. So what is the limit, and how old is too old for the IVF treatment, and when should we keep still trying? Once we are talking about the goals of the reproduction, and I am talking for my goals and goals of my team, the most important of those, is to achieve pregnancy as soon as possible, to maximize success rates for the first initial cycle for each patient, to reduce multiple pregnancies and guarantee safety in IVF, and also to help as many patients as possible by reducing the costs and considering the limits, especially the legal ones, as different kind of the IVF treatments are not available in all countries, and patients have a desire to get pregnant and to have babies in every location independently of what the regulations are. And the fact is that our biological clock is always running, and even right now, but if we are spending that time very useful by learning the possibilities of what is still possible. And if we are talking about the resource, so our resource is the ovarian reserve, which we are given since the very beginning of our life, and the maximum number of the follicles in our ovaries are during the antenatal growth on the 7 months of the development of the fetus. And then after several apoptotic reactions which are happening in our bodies, until the puberty, we have about 40,000 follicles. And during the fertile period, which is between 11 to 45 years old, we are all having about 400, 500 ovulated cycles, meaning we are using only tiny percent of the oocytes which are given during all our life, and 99.9% of our oocytes are lost. Unfortunately, because we are talking now together and the possibilities are given for those young patients as the fertility preservation of the oocytes, embryos, and even ovarian tissue. But if you are talking about having babies today, those alternatives were not possible several years ago, even 5-10 years ago. So we need to talk about opportunities which are given to those patients who are considering of getting pregnant right now. And because of the age and because of the fact that we are losing our potential, we are having less follicles, we are having less quality of the oocytes. And this is the fact that more and more patients who is coming initially to get their treatment, they are in their older maternity age. And we are facing the situation, we as a reproductive doctors, that once the patient who is over 35 years old is coming to visit us, her chances are already lower, and they are getting lower and lower with age. We have an alternative, and this alternative is a high success rate in case of using oocyte donation or cryopreserved oocytes which were cryopreserved before. But again, we should consider if this is a treatment which is recommended, or which is the patient is okay with this due to psychological factors or any other, or even the legal issues, if this is accessible in the home country of the patient, etc. And this is another fact, that the average age for a first delivery in the world is increasing. And if we will keep the trend, and the trend is that every decade the increase is per 2 years, so until 2100, the first delivery will take place in 51. And again, we as an IVF specialist, we need to have a decision how to help those patients, how to prevent this, how to save the materials, the resources, if this is possible, and also what to do in order to maximize the chances and the possibilities of getting still pregnant. And this is also fact that the patients and we all are living longer. That's why this is very logical that we are planning some reproductive plans. We are trying to get them later. Another thing, that the rate of the genetic abnormalities also increases with age. And even in young patients, if we are talking about quality of the oocyte or the quality of the embryos, some percentage of our oocytes and embryos will be aneuploid. Even if we are talking about egg donation, up to 30% of young oocyte being produced by donors, they will be aneuploid. And now we can prevent this because we can get this information from. And also, older we are, the higher percentage of aneuploidy, which is also the reason of the unsuccessful treatment cycle. How we see our full IVF cycle. So we are starting from the ovarian stimulation by selecting the appropriate medication and the treatment protocol and the regime. Once we got optimal number of the oocytes, we perform fertilization, and this is hard work of the embryology, and we should be sure that we have the best conditions in the embryology laboratory, and the cultivation protocols and the work of the embryologist is appropriate in order to maximize the chances of the embryo cultivation. Then this is the responsibility of the IVF specialist to prepare your endometrium and the whole body to perform all the needed screening tests and the decisions to be made in order to understand that the implantation potential will be the highest and successfully perform the embryo transfer. So this is the first opportunity to get pregnant. In case we are not pregnant, if we are lucky to have enough materials, we can perform frozen embryo transfer, but of course with the additions of the different screenings, like immunological treatment or a genetic evaluation or something which was not done, and this is our practice. Like, we would never do another embryo transfer until we are not sure what was the reason of the failure of the previous one. But if we are talking about older patients, it's not always that once we perform ovarian stimulation, we receive oocytes. It's not always true that once we receive even an oocyte, we would receive embryos. And we will talk about all these opportunities. What if we do have oocytes, but we don't have embryos? If we don't have even oocytes, what are the alternatives and the possibilities? So, what are the predictive factors for the successful oocyte development? This is first is age, of course. Second, and these are factors which are confirmed and which we consider as the most important right now. This is anti-Muller hormone. Probably every one of you knows already your level of the anti-Muller hormone, and doctors consider this somehow, and they predicted your outcomes based on this. This is also antral follicle count, and this is something that might be changed during cycle to cycle. And probably also you know that during one cycle you can have two follicles being seen on the ultrasound, and another cycle you can see 4 or 5, etc. And also what is important is, even if you are starting the IVF cycle, it should be proper medication and type of the stimulation protocol recommended. There are also some additions like the supplements and vitamins, like the testosterone, growth factor, etc., and some experimental treatments, but their efficiency is not absolutely confirmed. But we should keep trying. Also, like, we still recommend this to be used, but the fact is, what would be the outcome, how confirmed it would be. I would like to present you one of the unique techniques which we are using in our center. This is the ovarian rejuvenation for the oocytes and endometrium. And we are using platent-rich plasma injected into the ovaries and endometrium, and it works really well for those patients who have very low ovarian reserve, but they still have some IMH, and we can still see several follicles or even few follicles. The platent-rich plasma gives us the possibility to awake those small antral follicles or pre-antral follicles to grow them in the next cycle in order to perform the stimulation. For whom we are using this? For the patients with primary ovarian insufficiency, for advanced maternal age, premature ovarian failure, loss of the ovarian functions due to different external reasons, and ovarian dysfunctions. How it is performed? There are 2 steps. First, we are preparing the PRP plasma. We will draw about 20 milliliters of blood. We will do centrifugation of the plasma, and we will separate the red cells and the platelet. The procedure will take about 1 to 2 hours, and about 1 to 2 milliliters will be injected into the ovaries. The procedure will be scheduled immediately as soon as the material is ready, and the injection will be done the same as we are doing the ovarian puncture with the tiny needle under the ultrasound guidance. We will inject the PRP, distributing the materials across the ovary. The procedure is done under the anesthesia, and it's absolutely safe because this is the own blood, and there is no risk of the infections or the allergic reactions. So this is one of the, again, it's experimental treatment, but in Ukraine it is allowed, and it works, as I said, absolutely well for those who is not ready for oocyte donation yet and would like to increase the chances for the self-oocytes to be used. But once the oocyte is received, the very important is to check the genetic status of the materials, and we are having the opportunity in our clinic to check the oocyte status. We are performing NGS testing of the oocyte. We are the first polar body biopsy, and we may check if this oocyte is euploid, because euploid oocyte will produce as healthy embryo with the highest potential for the implantation. The same we will do, or we recommend to do, with the embryos. So as soon as we developed blastocyst, we are doing by the laser tiny hatching, like in the zone of the blastocyst. We are taking small piece of the material and test for the genetic status this embryo. And we are recommended to transfer only genetically euploid and healthy embryos to increase the chances for the success. Also, there are different factors. It's not only about having healthy embryo and well-prepared endometrium, like the endometrium should be proper structure and proper thickness. But also we need to remember about endocrine status of the patient, and this is what we are usually do. Like our package of the initial tests is wider than in some other clinics. We are checking thyroid function. We are recommending to check immunological status as well. We are checking potential for the implantation by accessing the window of implantation, and many, many more different tests based on the medical status and the previous outcomes of the patient. We usually and we always analyze all the previous outcomes, and we are trying and we are finding the reason why was the failure for this patient. Just few words about Ukraine, because I'm practicing in Ukraine for 13 years already with whole my great team. The whole Ukraine has more than 60 IVF clinics right now. All are private. What are the benefits and why Ukraine is such a friendly country for international patients to come? And this was an absolute practice until the COVID break, because in Ukraine there is legal oocyte donation and surrogacy, and we can also do export of biological materials to different destinations, to different countries. And also Ukrainians were recognized as the best looking nation in the world in 2019 by the UK journal. And this all brings us to the fact that we have been very active in receiving international patients to be treated on the territory of Ukraine. And in my experience, I've been treating patients from 32 countries. But right now we understand that the practice has been changed to transport the cryopreserved materials instead of traveling patients. And this is the opportunity which is given right now by the oocyte banks, that if you are located in the country where egg donation is possible and you are not able to travel right now due to the restrictions, or you don't want to risk yourself, you still can contact us and get the opportunity to receive biological materials into your clinic, into your country, and we will help you to understand the whole process and to manage all this. By this, we are offering frozen donor oocytes, sperm samples. We can even create embryos in Ukraine and bring them to your location, and we will perform and recommend the cryo shipping possibilities to safe and reliable transfer your materials into your home country. In our OOCYTE bank, we have extended egg donor catalog, sperm donor catalog. We are a licensed egg bank. We are following all recommendations of the European societies of different countries like FDA, Canada, Latin America, etc. Donors can be identifiable and anonymous as well. And in order to safely transport the biological materials, we are following all international regulations for the transportation of cryopreserved materials. And you need to remember that materials, cryopreserved materials, is your property. And you're right, every patient has a right to select a clinic where he or she would like to be treated, and also in the country. If we are talking about conventional oocyte donation, it's the most important and the most effective treatment for the older woman all over the globe. And this can be using fresh or vitrified oocytes. The success rates are the highest possible using the oocyte donation. If we have wide variety of phenotypes, you can easily select the donor materials. In Ukraine, all donors are with the proven fertility. We implemented genetically tested oocyte technique. This is the only and the first egg bank where we have oocytes being already NGS testing. We are the first polar body biopsy, so you can be sure that we avoid those 30% of aneuploid oocytes which potentially can come from the egg donation. And it's very easy to schedule. If you are coming to Ukraine to receive egg donation treatment, this can be done during one visit. And if you are happy to receive materials into your clinic, you are doing this in your home country, and this is absolutely appropriate according to all your conditions. What is also can be recommended for those older women in the older age, once you are creating and you can produce one or two oocytes, in order not to lose the possibility to have embryo transfer, because probably you have in your practical experience the fact that you produced one or two oocytes and you ended up without embryo to be transferred, we recommended so-called combined oocyte donation. This is for patients with the low ovarian reserve who are not 100% ready for the oocyte donation. And this is almost 100% transfer guarantee, meaning we will use two dishes. In one dish, we will put oocytes, your own oocytes, and in the another dish, this would be donor oocytes. Both would be fertilized with the sperm of your male partner, and on the day of the embryo transfer, checking the quality of the materials, we will decide together with the patient which materials should be transferred, and this also works absolutely well. Also in Ukraine, there are possibilities of alternatives for oocyte donation, so-called spindle transfer or pronuclear transfer. Probably you've heard about 3-parent babies. Again, it's experimental treatment, but I should say that IVF in general is just 41-year-old, and 40 years ago, everything was experimental. So we are talking just about the years of trying this technique, and the fact that this is not considered as a routine yet. But probably this is just because this is just the first steps. How this works, and in order to understand this, we will talk just a little bit about mitochondria. Mitochondria, it's like a battery of the cell. 90% of the cellular energy is produced by the mitochondria. And also mitochondria has its genome. It's about 37 genes. And if we are talking about young oocyte, we have a lot of mitochondria and their potential is high. But with the increased age of the patient, we are decreasing the levels of the mitochondrial DNA. Mitochondrial is getting morphologically changed, increases the deletions. And by the fact of this, we have adenosine triphosphate, which is giving the energy, also decreasing, and the reactive oxygen species increasing, which performing the damage of the cell and reduces its potential. So by getting mitochondrial dysfunction, we have lower IVF success rates, lower fertilization, and higher aneuploidy rates. And by the procedure of transferring the mitochondria and the pronuclei, we can receive mitochondria from young oocyte, and we can use nuclear mitochondria from the mother's oocyte and the father's oocytes from the sperm. So this is an absolutely unique technique. It's done only in few centers in the world. It requires really specific equipment and the knowledge of the embryologist, but this might be done, and this is done already. In order to maximize the chances, you can just see how many oocytes are needed in order to achieve high pregnancy rate and the live birth rate. And you can see that in order to get about 80% of success rate, we need to receive 30 oocytes. But if we are talking about reasons for dropout, you need to understand that those are psychological burden, physical burden, age, relational burdens, etc. But the fact that who would decide you when to stop, this should be just your decision. And just to show you some examples, I've got some publications and would like to share with you. This is Israeli one, and the fact that that country is covering all the IVF treatment by themselves, so patients should not pay anything for the IVF treatment. It was very interesting for them to evaluate how many patients would get pregnant with unlimited attempts being paid by the government within 4 years. The fact here is that this is all ages. It's not only older patients, but patients of all ages. So you can see that 95.5% of the couple conceived, 89.6% of couples gave birth to a live infant, 81% achieved the live birth within first 4 years, and 85 with 8 treatment cycle. So here we can see how many treatment cycles were performed, but the results are absolutely great. So when to stop? If we are talking about medical considerations, this could be number of the treatment cycles being performed already for a patient, number of follicles or oocytes received, IMH level, and blastocyst formation. But again, these are only indications for using own oocytes. And if we are talking about donor oocytes or experimental treatment, still there is something to talk about, because until you're having a womb, we can, by replacement of the cycle regimen, we can grow the endometrium and we have the possibilities to create embryos. And until you're having your endometrium and we created embryos, there is a possibility to carry the pregnancy. Officially in Ukraine, by law, there is no upper age limit for the IVF treatment. But of course, we are considering the somatic status of the patient, we are considering previous treatment cycles and the outcomes. And again, just to motivate you, this is the UK data of over 150,000 cycles, treat women, and over 257 treatment cycles. And you can see that once 9 treatment cycles were performed for patients of 42 years old with own oocytes, the cumulative live birth rate got up to 30%. It's not really high, it's up to 30%, but these are own oocytes 42 years old. If we are talking about own oocytes and age up to 40 years old, within starting even with 6 IVF cycles, it's over 60 and up to 75%. And if we are talking about donor oocytes, with starting from 5 treatment cycles, it's already over 80% and up to 95%. So this is something which is saying that you should ask yourself how many treatment cycles you had already, how different they were, and also I would recommend getting a second opinion from another doctor, from another center, from another country, because probably the facts how we are treating and how we are considering infertility are absolutely different. But if we are talking about older age, like starting already over 43, this is another publication about cumulative pregnancy and live birth rate through IVF for women 44, 45 years old. And here you can see that there is no increase after the third attempt. So you can try it for the first time, you can try for the second time, but the cumulative live birth rate would not be higher than 7%. This is something what we need to consider, we need to understand, and probably think about alternative here. Another publication saying about donor oocytes. Here you also can see that with receiving already over 30 donor oocytes for cumulative clinical pregnancy rate, the figure would be 89% and higher. Another issue, this is the ethical committee decision, and I would like to talk about this together with you. This is from the ISRM, and the recommendations are the following, that for the purposes of the statement of futility, it is between 0 to less than 1% chance of achieving the live birth, and very poor prognosis is between over 1% to about 5%. So it should be discussed with your treating physician, and the treating physicians should consider what would be the expectation for the success here. Clinicians may refuse to initiate a treatment option they regard as futile, providing they have informed the patient with regard to the option of the futile. And clinician may refuse to initiate a treatment option if the prognosis is very, very poor. But protecting fertility center with their success rate, they are not allowed to say no for your treatment. And upon request, clinicians may treat patients in cases of futility or very poor prognosis, provided the clinicians can access some benefits and inform the patients of the low odds of success. And thorough discussions are advisable at the beginning of the patient's physician's interactions when patients have indications of futility or very poor prognosis. And programs and clinics should develop policies and to guide decisions about treating for patients with futile or very poor prognosis. And those discussions which we just had above, these are those program and the policies about like some more options to be given to patients with the older age. And something, this is very, very important as for this talk publication, just for 5 days ago from October 5th, 2020, which say that the older you are in your last birth, the longer you will live. So this is the association between the maternal age at last birth and the telomere age. So this data provides us the new insight into the biological relationship between reproductive history and long-term health. And another, what is very important and what we follow in our clinic, the fact that unexplained infertility generally means that the physician failed to find the true cause of the infertility. So if you would consider to be treated or you would like us to consider your treatment history, we would be happy to try to find the true reason and true cause of your infertility. So to conclude, different treatment options may be recommended in IVF to achieve a goal of the parenthood. Second opinion is recommended due to specific limits in the countries. The most effective treatment for patients in advanced age is oocyte donation. Experimental treatments in IVF are available. Some of them are already effective and may be accepted widely in the future. The most effective treatment for patients in advanced age is the oocyte donation. This is just once again. And if you are listening to this webinar and you haven't tried all mentioned above, you should still keep trying. Thank you for your attention, and I will be really happy to answer your questions. You can see my contact details here, also contact details of the clinic, IVMED Fertility Center in Kiev. Also, for the oocyte donation, the contacts of the OVOGENE Egg Bank. And if you need to travel your materials from one destination to another, the courier service details. Thank you so much, and I am ready to your questions.
And wonderful. Thank you so much for that very interesting presentation. Lots of nuances here as well. So we had some patients that already wrote that it's very, very interesting. So huge thanks for that. As always, you've been brilliant with explaining everything. And well, now it is time for our questions. And as you can see, there are plenty of those questions from our patients right here. So let's get started. Okay.
Yeah, sure.
Perfect. So okay, the first question it's in regards to I believe the new methods that you have provided. What is the age cutoff for this?
So let's go step by step. I just would like to say once again, to be understandable, that in Ukraine there is no upper age limit. Still, even there are no recommendations. Like every clinic would decide by themselves, by the medical committee, what would be the best option for the patient who was referred to that clinic. Of course, the very important fact is the somatic status of the patient and the histories of the previous outcomes. And we are always in communication with the treating physician from the home country, and we would never proceed with the treatment if we are not in touch with such a specialist. If we are talking about specific treatments like the PRP therapy or ovarian rejuvenation, until we can see some levels of IMH, like I would say we've been trying even 0.1, but the question is we can try once again, and if we can see the follicle which is growing, we would proceed with the stimulation. But in such cases the outcomes are really different. Sometimes we are not getting follicle grown. The best outcomes with the ovarian rejuvenation we are getting with the level of zero point 0.3 IMH and higher. So I would say that all patients for whom we did PRP therapy, we have several indications that we've seen IMH being increased, FSH being decreased, and new follicles being grown. And as soon as we have seen this, we are starting the stimulation. If we are talking about mitochondrial donation or pronuclear transfer, the maximum recommended age is 43. But again, it's based on each cycle evaluation. Usually, if still we can see some levels of the IMH and positive positive outcomes for the treatments in the past, meaning receiving at least one oocyte, we would proceed with the treatment, because we need to be sure that we are receiving oocyte in this treatment. And if we are talking about egg donation and surrogacy, again, as I said, it's based on the somatic status and the general health of the patient.
And thank you so much for your very first question and of course your thorough answer to that. And let's have a look. If you could tell us where can we access the catalogs?
If you will be able to provide your email, I will forward this to the team, and they will send you the access. But also on the website, it's ovogenebank.com.
Wonderful. Thank you so much for this as well. All right. Next question is I am 42 and I have very low ovarian reserve and 4-5 AFC. What is the best for me to use my own eggs or donated eggs?
Thank you, Silviana. Again, I would like to get answer into my question. If you have been trying IVF before, and what were the outcomes in terms of how many oocytes were produced, what was the quality of the embryos, etc. But if would talk just statistically, I think still with the 4 antral follicles and 42, your chances of receiving 2 to 3 oocytes should be quite high. But the question would be of blastocyst formation probably, and the euploidity of your embryos. But again, and And the second question would be how long you are giving yourself time until you will get pregnant. If you would like to get pregnant within several months, definitely oocyte donation. If you are not ready for oocyte donation and you would like to try the last chances or some chances, which definitely would be lower in comparison to the oocyte donation, you should keep trying with own.
And wonderful. Again, thank you so much for that advice. And actually, next question is quite similar as it is. I am 44 and have 1.4 AMH, but I still want to use my own eggs.
Some patients who have been PCOS patients in their younger age, still in the age of over 42, 43, we can see IMH level like this. And the potential to receive more oocytes in this age is higher in comparison to, let's say, even a previous case. But still, the percentage of aneuploidity, unfortunately, is the same or would be the same. So if you would like to try, I would say that you should try. Like we would consider you as a low prognosis, but still with some prognosis in about 3 to 5% or up to 10%. If this is something what you would expect and if you would consider, so please, yes, go ahead.
All right. Again, thank you so much for that advice. All right. Next question also is right here. So I'm 40 years old. My AMH is 1.96, nanograms per millimeter, and AFC 8, FSH 7.6. What are my chances using IVF with own eggs? How can I improve my egg quality? How should I best prepare for IVF?
Thank you so much. Again, if considering just case by case, I would say that this case is the most optimistic one because of the level of the IMH and FSH is absolutely fine. Antral follicle count is great. So I would say that your chances would be even between 20 to 30 or even over 30%. But again, to improve the egg quality, we have different recommendations, but they are not as a clinically approved. These are not something what was given as a recommendation by any society or something. This is just from our experience, like the complex of the vitamins, testosterone, etc. If you would send us a mail, we will send you the scheme but usually we recommend this to improve the oocyte quality and to take these supplements 2 to 3 months before the treatment cycle. This is what would I just recommend to do prior to the IVF treatment. But also I would like to recommend to start treatment as soon as possible because with every month we are just getting older and older and the chances are getting down. So to best be prepared just to start the IVF.
And again, thank you so much. That was excellent. And well, there is another question, of course. And within that, there are like few questions. Okay, so let's start with, I will read it out. Of course, we can take it one by one. I'm 42 and a half with AMH 3.1 pmol and AFC of 11 on last count, FSH of 9.5. My TSH is 2.9. I understand that TSH for IVF should be below 2. I am currently taking thyroid regulation medication. Can I start IVF cycle with elevated TSH, or first it will have a negative effect on success of the procedure? What are my realistic chances of successful IVF with such a low AMH, AFC 11?
Mm-hmm. Thank you, Patricia. Again, all the measurements like the IMH, antral follicle count, FSH is also absolutely fine. TSH is within the range being normal. It's just a recommendation to have it below 2. And if you already are taking medications to regulate your thyroid function, you just should follow the changes, But I think that within 2 to 3 weeks, even the changes will be already there. So the most important is the age. It's already 42 point something. So again, I would recommend to start as soon as possible. What is recommended, what you just need to consider that for all patients over 38 years old, we are recommending medications to FSH plus LH, just to consider with your doctor and double check, because LH is really important for women in the advanced maternal age, and this would be the best stimulation regimen. If you have no endometriosis, if your cycles are still regular, it could be short stimulated protocols with antagonist and probably RCG triggering, not to avoid freeze all and maximize the fresh embryo transfers in the end. But maybe you should also consider PGS, PGD for the embryos, because if you will get the antral follicle count is huge, is really nice. If you will get several oocytes, it's very important to know which embryos would be euploid. So here are the recommendations, and again, just start as soon as possible if possible.
All right. Once more, thank you so much for that. Another question, a little bit longer one as well. And Dr. Uliana, it appears to me that you have moved clinics. What is the maximum age of treatment at your new clinic for embryo transfer of cryopreserved embryo that I have? You have previously mentioned that you have a partner clinic in Canada. Do you know if I can bring in my cryopreserved embryo formed from anonymous donor egg into Canada? What is the maximum age for pro-nuclear transfer? This can be done once you have reached menopause. Is that correct?
Thank you, Dorothy. I am happy to hear you. Yes, I moved to Kiev, and I'm, as you have seen, I'm working together with the team of the IVMED clinic in Kiev right now. This is a great clinic, a great team of really moving fast and developing embryology with all those potentials of the mitochondrial pronuclear transfers, etc., NGS testing. So as I said, the maximum age for the treatment is considered during the clinical decision of all doctors after we have received the medical documents related to the patient and all the history. Also, if the decision is positive or we need to consider something else, we are asking the patient to connect through Zoom or Skype. Uh, and yes, we have clinics in Canada, but due to the changed regulations recently, they will not accept absolutely anonymous donation right now. And also, all materials which are shipped to Canada, they need to be FDA tested, very similar how it is for the USA. So I think it will not be possible to transfer those materials you are mentioning right now. The maximum age for pronuclear transfer, recommended age is 43, but again, it's case to case, considering previous outcomes and age and potential to produce oocytes. And if the menopause is reached already, probably there is no possibility because we will not be able to get follicles. So the probability of getting oocyte will be really, really low. I hope I answered all.
Yes, of course. Thank you so much for that. And again, that was a thorough answer indeed. And well, Dara, of course, thank you. There is a thank you, sorry, from our previous patient as well. Thank you very much from the previous answer. And well, another thank you from Dorothy here. Yes. Thank you. Excellent. And let's have a look. Of course, there are plenty more questions coming up. So let me go to the next one straight away. I'm 43. I had a recent antral follicle count but could only see 2 follicles on each side. I was told that this was the result of C-section 15 years ago. My AMH is 4.2 pmol. Is this good?
The decrease in the follicle count could not be a reason of cesarean section. only in case it was laparoscopy and there was something was done to the ovaries, but usually cesarean section has nothing to do with the ovaries, so it's not connected one to another. 43 and 4 follicles each side. uh, Probably you will be able to produce 1 to 2 oocytes. Again, the question is, have you tried, and what is your experience on reacting into the medications? Um, 14.2 picomoles, it's into our levels, it between like 2 point something. It's still quite good IMH. So I think you should, if the question is to use your own oocytes, there is a reason to try here. Maybe also you can try ovarian rejuvenation if this is, unfortunately, I don't know where you are. So I don't know if this is, it can be done in your country or you should travel somewhere. And the opportunities to travel right now are really limited. But if patients would like to travel to Ukraine for treatment, they are able to do this. Even during the quarantine, stricter quarantine than now, we sent the documents confirming the patients is coming for medical treatment, and there was no questions in the borders. The only issue if still there are flights, etc. But our international department will be happy to help you with that and to accommodate and to help to answer all the questions regarding the flights, etc.
Okay. And once more, thank you so much for that answer to this
Thank you.
question. And let's have a look at the next one. What would your view be for having PGD tested good embryos from successful previous donor and transferring them into a surrogate mother who has only given birth 14 months prior with her own baby? Her BMI is 21, her blood type is B plus, and my donor's blood type is 0 plus, like mine, and my husband's blood type is 8 plus. She seems healthy. What do you think? Would she be a good candidate? Is it normal to use surrogate only for 15 months after birth? By the time she will do our transfer, it will be 17 months after birth of her own child.
A good question, Angela. Actually, in our clinic, we do not recommend for the surrogacy to have another attempt, either surrogacy or having a transfer after the birth of a baby within 2 years. But if you will postpone a little bit, and if the lady, again, we need to check the status of the surrogate, like if she's healthy, if her pregnancy was without complications, if she is not breastfeeding, if there is a list of the tests which are need to be done for the surrogate mother. After checking that, I would be able to confirm or not. There is like the information which is here. I would just only say that I would recommend to wait a little bit, and that's all. But in general, everything looks fine in terms of the blood type. It's absolutely fine.
All right. Thank you so much for that. Someone is typing, so I'm not sure. Possibly it's a follow up, but
Mhm.
let's go to the next question. And of course, we will always be able to go back. Oh, sorry. There's okay. Yeah, there's a follow up. So let me go straight to that. So, why is it needed to wait?
The pregnancy itself, this is the status of body of every woman, independently it's a patient or a surrogate mother, that you have some conditions being changed. And surrogacy is very important procedure and very responsible one. So just from the clinical side, we would like to be sure that we have the best conditions. And depending again on how was the delivery of that previous pregnancy, how was the pregnancy itself, what is the status of the patient, of a surrogate mother. Today, we are recommending to have embryo transfers within 2 years and later after the previous delivery. But every case can be different. This is true. And we need just to have more information in order to confirm this or to say we still need to wait. But general information is like this.
Okay, thank you for explaining that once again to us as well. And let's have a look at the next question that we have. And of course, there's a thank you from Angela for you right here. Okay,
So,
next question is, so what, oh, sorry, it was just this I have showed. So let me,
yeah.
sorry, go to the next one right here. With COVID and travel restrictions, we decided to freeze my partner's sperm. In case I need to travel by myself, I am wondering if using fresh versus frozen sperm has impact on success of the fertilization.
I would say that this would depend on the quality of the sperm sample. But if clinic decided to freeze it and there was no recommendation that the quality of the material is low or that could be any risks here, like that it's still recommended to fly and to produce fresh over, so it should be absolutely fine. So we it's better to understand the status and the sperm quality to answer this properly. But in many cases, we recommending the same. So if patients would like to avoid staying longer in Ukraine, for example, or if the male partner cannot travel, we are just recommending to freeze the sperm somewhere, and we are sending the courier and we bring materials over to Ukraine. So it's any complications for this. Usually, sperm sample has millions of motile sperm, and even if there is cryotolerance, it's in normal sperm samples, it's only up to 30% that we are losing, and we still have enough for the fertilization. So in general, it should be fine.
Excellent. Thank you so much for that. And of course, there's a thank you from the patient for you right here. Thank you. All right. And let's have a look. The next question is up. So, do you use IVM? If yes, what are the results you have got?
Hi, Margie. Not like we have the technique is in place, but because the results were not really high, or like the reason why doing IVM. Usually, IVM was done for the oncological patients in order not to stimulate them because of the risk of the high level of the estrogens. And by avoiding this, we did IVM. We do not have really many of those patients. That's why it's not really common. But the technique is there, and because there was no high numbers, I cannot provide you with proper data. But I will be able to find out more and will be able to provide you more information if needed. But also, I'm wondering why you're asking. What is the reason from your side to do IVM?
Okay, understood. And just let me remind everyone that, of course, I have just sent you a link to where you can use, and there's a button to simply contact the IVMED and, of course, Dr. Uliana. And I'm sure all of them will be more than happy to assist you and provide you more details as well. And let me go to the next question. So, what are the top 3 supplements you recommend to improve quality for women over age 40?
So it would be testosterone, coenzyme Q10, and vitamin E.
I'm sorry, we didn't get the last supplement. Could you please repeat that?
Vitamin E.
Okay, vitamin E. Thank you so much for that. Excellent. All right, let's have a look. Of course, there is another question right here for you. I am 45 and have IMH of 8.5 and going through a donor egg treatment. At egg retrieval, I had 3 follicles, but there were no eggs. What are my chances with the different treatments you mentioned? And my IMH is 8.5 pmol.
Yeah. The question here is that probably I would wonder what would be the FSH level here, but if still there is a possibility to try own eggs, I would try to perform ovarian rejuvenation But again, the probability of getting, we potentially would decrease the FSH and increase the IMH a little bit, but we need to check if still we will get more follicles to grow. I think egg donation for your age and the parameters and also previous outcome is the most reliable and the right procedure.
All right. Again, thank you so much for that advice. All right, next question, of course, it's also here. I'm 46, AMH at 45 was 4.5, considering egg donation, but still holding out for own eggs. Anything you can add?
Yeah, Martina, very similar to the previous patient. And the something what is the most negative here, unfortunately, this is the age. Uh, I think that both of you also can try combined egg donation. Like once you are receiving IVF treatment and gonadotropins, even if you are ending up with no follicular growth, or if you're ending up with the follicular growth but no oocyte, this still also can happen. Anyhow, your endometrium is growing, and you should not stop treatment. You can just proceed with the egg donation starting from the time of your OPU. And OPU is day 0. This is a day when your egg donor also should be punctured, or in this case, synchronization sometimes can be complicated because you need to postpone or to get faster someone, and this is not always optimal in timing. That's why the vitrified oocyte donation would be recommended, because once you are getting materials from the egg bank, you should sow them exactly on a date and a day when you are having your oocyte retrieval. And the oocyte vitrification is sowing absolutely is great technique. Like survival rate is over 95%. We are not losing materials. Fertilization rate and the clinical outcomes are the same. So still, there is a true that more publication and more beliefs, even between the doctors, are for fresh oocyte donation. But my experience shows that vitrified oocyte donation has many, many more benefits in comparison to the fresh. As a fact of no synchronization, as a fact that you can predict how many oocytes you need in order to produce embryos. We are usually calculating 4 oocyte for one healthy blastocyst. So also in a fresh egg donation, there is a risk or possibility, but also it's a risk to create surplus embryos, meaning if you are in your older age and you stimulated one donor per patient and you received 5 to 6 blastocysts, but you need only 1 or 2, so you will have additional embryos which will never be used. And someone could potentially have been using part of those oocytes from the donor. So vitrified oocyte donation has many, many benefits. So I would recommend to try combine if you would consider this as well.
All right. Thanks, Amelia, for that one as well. That's, of course. Next question. There are like few questions left. We will be shortly finishing, but of course, let's go to the next. So I'm 46 and 47 next year. I want to use donor egg with my husband's sperm, but would like to have at least 3 children. Is it possible to use the same egg donor and freeze the additional eggs blastocyst? What would you recommend to have successful IVF and having a family?
Thank you, Snezana. It's a great planning from you. And yes, absolutely. So if you would consider oocyte donation, I would recommend, like probably for the successful treatment of having 2, 3 babies, you would need to have either full fresh egg donation or receiving between 12 to 15 or 18 vitrified donor oocytes. You should expect with the good quality sperm of getting 4 to 5 or even 6 blastocysts out of this. And then with the egg donation, it's not usually recommended to perform PGS testing, but you can do this as well. And this would be like a full material to be used in advance, like, or in the future. And also you can order some vitrified oocytes if you like. If still in a bank you have more materials being available, let's say you can do a first trial of 12 oocytes, worm them, fertilize, cultivate until blastocyst, understand how many blastocysts you received, and if this is enough for 3 embryo transfers or 4 embryo transfers, and then you can order the materials from the same donor. Usually donors are donating several times, so it's a very common thing that you still can contact with the oocyte bank and get the same donor materials.
Thank you for that question again, and of course for your help with that. And let's have a look. So, what is the percentage of euploid embryos at 40?
Statistically, it's between 15 to 20%.
Okay, excellent. And can you tell us something about how fast does the MH level drop at 40, 41, 42, 43?
It also, the question is, what is the starting point? But if the starting point is already, let's say, 1, so the decrease, it would be individual, but the average is getting reduction in 50% every year. So if we already on the low levels, today I have 1. In 1 year I will have 0.5. In 2 years I will get up to almost 0. So it's quite fast.
All right, thank you for that clarification as well. Next question is a bit longer. I'm 43. I have been trying to get pregnant for 4.5 years and I have 0.2 AMH. I have done an 8 IUI and 5 or 6 IVF. I've never get 2 blastocysts. I have had 2 day 3 fresh transfers and one resulted in pregnancy last year, but I miscarried at 10 weeks. My husband, who is 44, has low count, quality and motility, DNA fragmentation, and very, sorry, not sure. Would you recommend we move on to donor egg or donor sperm? We haven't wanted to donor, which would be a better choice. Excuse me. Donor egg or donor sperm, and why?
It's very really great question. I think that during all these trials of 8 IUIs and 5 or 6 IVFs and such a male factor, probably the reason of failed attempts was more connected to the male factor than to the oocytes. But because today is 43, I think that it's already too late to try donor sperm, but maybe it's still reasonable. But again, we need to consider the fact that in 43, the percentage of success would be about 10% if you will use donor sperm here. Or double donation, but this is something what you are just not considering here. So the options are still, I would say that, but we have 0.2 IMH. Yeah, complicated question. I think that the donation would be definitely recommended. Either your eggs and the sperm donation as getting no implantation and miscarriage in the previous treatments, and this can be connected to the male factor in this situation, or double donation.
All right. Okay. Understood again. Thank you so much for that explanation and your recommendations as well. Okay, next question is, so is there any clinics in Sweden that works with you? Do I have opportunity to get help of your clinic?
Yes, we have clinics in Sweden. We are working with, if I'm not mistaken, I remember one very well. It's Dinhal San, but I would like you to get in touch with us on email, and we will be happy to provide you more information and contact persons there.
Okay, excellent. Thank you so much for that. All right, next question is, so I wanted to know if IVM can be used to grow immature MIX to mature M2, right? M1 X to mature
Yeah,
to M2
yeah.
X.
Yes, IVM is recommended as a technique to grow immature or even the previous maturation rates of the oocytes and up to M2 oocytes. But again, it should be clear medical indication for this. Let's say if the reason of getting M1 oocytes is improper stimulation protocol, so then we should just change the protocol or understand what is not working properly in this stimulation protocol, because there is no other reason to receive M1 oocytes. So if the stimulation is proper, it should be M2. If we are puncturing follicles on a size of between 10 to 12, 13, 14 millimeters, we are expecting to receive immature oocytes. Then we can grow them up to M2 in the laboratory conditions. But what is the reason not to stimulate a patient up to M2 in the ovaries? So then chances in comparison to IVM, at least in our experience, would be definitely much higher. So it should be proper medical indication for IVM.
And thank you once again for the clarification and explanation to this question. All right, next question is up as well. So, what is your view of folate instead of folic acid in the prenatal vitamins, probiotics, vitamin D, fish oils from small fish in clean waters? Which brand would you recommend that are organic, preferably?
Dear Angela, there are so many producers of those supplements. We are not really recommending any brands because worldwide they are so much different. The folic acid is recommended, of course, and the probiotics, but it's better. There is no one recommendation for all. Like there is something general, but again, we need to consider different factors. So it's better to have individual recommendations for this.
And thank you so much for that. As I mentioned, of course, there are like three short questions and we will be finishing. So let me just go straight to this one. Is there a clinic in Germany who is collaborating, and also Portugal?
Yes, in Portugal, because oocyte donation in Portugal is legal and officially performed, we are collaborating with clinics in Portugal. I will be happy to provide you with some data. But Germany, their oocyte donation is not allowed. So we can only transfer embryos if those are embryos from your oocytes and your sperm partner sperm. So this is the only possibility there. That's why the options are really limited. From Germany, we would recommend to travel somewhere which is close around, like Poland or even Ukraine or something around there.
All right. Thank you so much again for that. So Portugal, yes. Germany, no. Okay.
Yeah.
Thank you. All right. There are like two questions just shown right here. So, do you think assisted hatching is necessary or helpful for my cryopreserved donor egg embryo grade 2AA?
Um, Assisted hatching, like we have very positive experience by using this, but and we do assisted hatching for all embryos which were vitrified and warmed, and also for the embryos created from the vitrified oocytes. So I would say yes, but once we would prepare this embryo for the embryo transfer from 2AA, we would grow it until we will give the opportunity for this embryo to grow until 3, like 3AA, and then we will see what is the development, how fast it is developing, and then decide regarding should the hatching be done here or no. Because like if the development is absolutely proper, so maybe we should avoid helping this embryo and just leave it without. It's a decision made by the usually by the embryologist together with the doctor and the patient.
All right. Again, thank you so much for that then as well. And of course, there's a thank you here from our patient. And so, do you recommend CoQ10 ubiquinol how much?
Yes, the CoQ10 is in the list, but I need to double check of the dosage. Sorry, I am not able to provide this right now.
That's perfectly, of course, okay. No problem here. So remember that you can use the link I have just sent to you. You can contact Dr. Uliana and her team, and of course, they will help you out with some more details. And well, it looks like this is our final question for today. So let's have a look. So, what are the main differences between blastocyst A, B, or C?
There are huge differences between those. Morphological grading of embryos, this is an invasive but very informative information we can get from the embryos. You know that there are different machines like the time lapse technologies and some others which are helping using the artificial intelligence um, to say in advance what would be the potential of these embryos to be implanted. So by just simply grading embryos between A, B, and C, I would say, and this is true, that A is the great embryo, B is the embryo with some morphological disorders, which is equal to the medium quality, and C is a very low quality embryo with very low potential for implantation. And there are many, many publications, and we also follow this in our practice that the implantation potential for AA or AB, which are considered a good quality embryo, is high. BB is already lower, and BC is the lowest. Still, we have implantations, but the potential is very low.
Okay, excellent. Thank you so much for that. And as I mentioned, it looks, yeah, it does seem that this is our last question. But of course, again, let me remind everyone that this is possible for you to simply get some more details from Dr. Liana and her team. All you need to do is just click on the link. There is an option there. And well, Dr. Liana, thank you so much once again for joining us because as you can see, there are plenty of thank yous coming up right here. I could just show you those right here. And of course, you can see such a great informative session. And so someone is going to see you possibly soon. So this is the message from our other patient right here for you.
Yeah,
And
thank you, Susanna.
there are more of those,
It
of
was a
course.
good time of traveling around, and I would like to thank you all. It's a great pleasure for me to be with you. And I hope it was really helpful and this will motivate you. What is the most important? To keep trying, to keep more options and to use all this statistical data, but also believe in the surprises from God and from everything what we believe in. And I would like to wish you all a great health and for all of us to get back to the normal lives very, very soon. And I will be happy to see you in Ukraine if this is your desire and I can help you with your dream into the parenthood. Thank you so much.
Thank you so much for those words. It definitely, this is an excellent finish for that, for sure. So, as you can see, those are coming up more and more. So, excellent webinar. Couldn't agree more, really. Thank you. I know this is just one of those webinars with you, and so till our next webinar, I hope pretty soon. I mean, I'm not the only one here, I'm sure. So, Thank you so much, everyone, for joining, for your questions. And I am very, very happy that you have found it so interesting and so useful. And of course, remember this has been recorded, so it will be available tomorrow on our website, myivfessence.com, but also on our YouTube channel. So just go ahead and subscribe. That way, you will know when the video is uploaded. And of course, there are more plenty of those events coming up. We will be back tomorrow. Actually, tomorrow we have actually two webinars. First one is at 1 p.m. UK time because we will be connecting with Australia. And the second one is in the evening. So I just hope to see you there as well. Thank you so much. Have a lovely evening. Thank you all and have a good night. Bye.